Moving on to the assessment of the shoulder and the shoulder girdle. The shoulder should be considered as a complex rather than a single joint. Shoulder pathology may be associated with dysfunction not just of the shoulder joint itself, the glenohumeral joint, but it may also be as a result of impairment of movement at the acromioclavicular joint, the sternoclavicular joint, movement of the scapula on the thorax, the scapulothoracic joint, which is not a true joint but it's a pseudo joint, and or the glenohumeral joint too. In addition to that, we need to consider the influence that the spine, the costovertebral and costosternal articulations also have on shoulder joint movement. So all of these joints should be assessed or should be considered in the assessment of a shoulder pathology. Not just in terms of whether they are the root cause or the source of the pain, but also whether they are contributory factors. The subjective assessment of the shoulder joint will follow a similar pattern to any other joint. Many pathologies are of insidious onset around the shoulder, so overuse problems and degenerative problems around the shoulder are very common, and it's important for the clinician to be able to differentiate between whether the origin of the injury is traumatic or whether it's of gradual onset. Pain also around the shoulder may be local, so an individual may come in complaining of pain in a specific spot, but very commonly there is referral, and not just neurological referral but also somatic referral. So something like a subacromial impingement of supraspinatus can often refer down to the lateral aspect of the elbow. Individuals may also describe functional loss or instability, and sensations of clicking, snapping, grating, locking and numbness are very common. In terms of the mechanism of injury, we can broadly divide these up into four main categories. There are the traumatic injuries, the fractures, for example, fracture of the clavicle, of the acromion, of the humerus, sprains, subluxations, dislocations, and so on and so forth. There are instability signs. So somebody may come in, a patient may come in complaining of pain arising from the shoulder for no specific reason, but what they complain of is whenever they load the shoulder up, there is a sensation of slippage, of subluxation, of instability, and so on, which in turn may go on to lead to other problems, so impingement or tensile problems of the tendons themselves. Some problems are as a result of poor posture, and we'll discuss scapular versus thoracic versus humeral posture in a moment. And finally, the last category are the impingement signs. The anatomy of the shoulder is such that a number of structures pass between the coracoacromial arch and the top of the humerus. These structures are very prone to impingement, structures such as the subacromial bursa, supraspinatus tendon, infraspinatus tendon, and the biceps tendon. The clinician must do is they must decide whether the injury is acute, an acute pathology on a chronic background, or a chronic pathology. There are some specific areas that you must rule out when going through your subjective assessment of the shoulder. Heart problems will often radiate pain into the left shoulder and down into the left arm. The lung or diaphragmatic problems, so tumours and tuberculosis, may also refer pain along the C4 and C5 nerve roots, which is over the shoulder, the upper shoulder and upper arm. Spinal fractures or spinal involvement, where we've got neural pressure, that can very commonly refer to the shoulder, and other factors such as tumours or cancers. We've got to be very careful of those because it's not at all unusual to find tumours that can refer pain to the shoulder. The cervical and thoracic spine in particular will refer pain to the shoulder. And disc herniation or disc degeneration will often give very specific patterns of pain across the back of the shoulder. The elbow joint, temporomandibular joint, the ribs and abdominal problems can also refer to the shoulder joint. So be aware that sometimes the site of the pain is not necessarily the source of the pain. When we move on to the objective assessment, again, it follows a similar pattern to other areas. There is a significant amount of emphasis has to be placed on postural assessment here, in particular the interrelationship of the spine, the scapula and the humerus. We then move on to the ranges of movement, active, passive, and then resisted muscle tests. Then there's a group of special tests to try to assess certain areas, specific areas or specific structures, before moving on to functional activity and then confirmatory palpation. When we look at the spine sits, it's a series of building blocks that all sit on top of each other, and the spine itself sits as in a thoracic lordosis, in a cervical lordosis. A thoracic kyphosis should demonstrate a gentle curve posteriorly, and then a lumbar lordosis. Abnormal alignment of the thoracic spine include things like we see here. This lady's got a significant hyperkyphosis, an increased kyphosis of the mid-thoracic region. This increased kyphosis will lead to altered position of the scapula, which will then in turn lead to altered movement of the glenohumeral joint. So this kyphosis may, although it may not be the source of the pain, this may be a significant contributory factor. Similarly, an excessively flat thoracic spine can also lead to shoulder impingement problems. Scoliosis is where we look at the spine from a posterior aspect. So in an anteroposterior direction, the thoracic kyphosis and lordosis is normal, and but when we look at it from a posterior aspect, the spine describes an S shape, and this curvature, this mediolateral curvature of the spine, can lead to abnormal positions and abnormal loading and abnormal movements of the shoulder girdle and shoulder joint. When we move on to the scapula, one of the things we look for symmetry and the relationship of the scapula with other bony structures. So for example, the border of the scapula, the medial border of the scapula, should be positioned approximately 3 inches away from the midline of the thorax, and it should sit fairly parallel to it. The scapular height usually sits approximately between the 2nd and the 7th thoracic vertebrae, and the scapula should be fairly flat against the thorax, and because of the shape of the thorax, should be rotated approximately 30 degrees anterior to that frontal plane. But there shouldn't be any winging or abnormal tilting. Here we can see a lady that has an abnormally positioned scapula. We can see these tapes here are marking the medial border of the scapula. And what we can see on this side in particular, we can see that the inferior angle is closer to the midline than the root of the spine of the scapula. In this situation, that's known as a downward rotation. And what happens with a downward rotation is the acromion process gets pushed down towards the humerus itself, increasing the risk of shoulder impingement. Depressed scapulae, here we can see on this chap, the scapula itself looks like it's lower than it should be, so it doesn't sit the top of the spine. The top of the scapula itself doesn't sit opposite the 2nd thoracic vertebra. In this situation, we often have excessively long upper trapezius, but tight structures such as latissimus dorsi and the lower fibers of pectoralis major. An excessively elevated scapula, here we can see shortening of the upper fibers trapezius. In this situation, you can see the bulk of the upper fibers trapezius holding both scapulae up. This then changes the position of the glenohumeral joint and the position of the acromion process or the coracoacromial arch, and again increases the risk of impingement of the subacromial structures in particular. An An adducted scapula is where the scapula is excessively retracted and the medial border of the scapula sits very close to the thoracic spine. This is often as a result of tightness of the rhomboid and trapezius muscles, whilst the protracting muscle, so pectoralis minor and serratus anterior, is often considered excessively long. That then impedes how the individual will move because the scapula remains close to the midline rather than having this free range of movement. So there's often an impaired range of movement of the upper limb. This is the opposite. This is where the scapula is abducted. And so this time the scapula has moved around the thoracic wall and the individual appears excessively rounded across the posterior aspect of the scapula itself. This is often caused as a result of tightness of serratus anterior, and it may be associated with tightness of pectoralis major as well. Right, this is an example of a tilted or a tipped scapula. In this situation, what we see is the inferior angle sits posterior relative to the rest of the plane of the spine of the scapula. When the individual is last asked to lie down, we can see there's a significant distance between the acromion process and the bed itself. This is often as a result of tightness in pectoralis minor in particular, and the cause it may lead to impingement of structures like the long head of biceps and the subacromial bursa. The scapula the scapular position can vary in more than one plane. So sometimes we can have individuals that have got a depressed, so a lowered and then tilted scapula, or an abducted and then tilted scapula. Both of these abnormal postures are fairly common. Winging of the scapula is identified when the medial border, the vertebral border of the scapula, protrudes posteriorly. In winging, as we can see in this situation on one side here, we can see the scapular border is lifted away as the individual puts her arm behind her back. This is often indicative of weakness of serratus anterior. The scapula may also be rotated abnormally. So an upward rotation of the scapula is where the root of the spine of the scapula sits more medial than the inferior angle of the scapula. And again, this is often as a result of tightness in the upper fibers of trapezius and lower fibers of trapezius.